Our next presenter is Dr. Frances Connor. So Dr. Frances Connor is a paediatric gastroenterologist at Royal Children's Hospital in Brisbane. She trained in Brisbane, Sydney and the United States. Dr. Connor wrote the Queensland Guidelines on the treatment of constipation in children and contributed to the Queensland Health Educational DVD on managing continence issues in children in primary care. She has extensive experience in the management of children with constipation and fecal incontinence. Many of her patients also have urinary symptoms. And welcome, Dr. Frances Connor.
Just while Blair gets that up. So I deal a lot with constipation, but many of the children also have urinary symptoms, and I'm going to touch on the interplay between the constipation or the bowel dysfunction in general and urinary symptoms, but not go into too much detail. That was a fabulous introduction with Wendy's comments in the last couple of slides because it really ties directly to my work. But I'm not going to go into a lot of science today. I'm more going to go into, as healthcare practitioners, seeing children with urinary symptoms, how would you recognise if there's a bowel problem? How would you recognise if they need to go and see a doctor or have further investigations? And how's the medical management likely to play out in those children so that you can be very familiar with what the doctors are going to be doing and working hand in glove with that if necessary. So, as you would know, these are very common problems. So around 10% of children can be constipated, about a quarter of children can have bladder problems, and in children presenting with urinary problems, more than half will have an underlying bowel problem as well, often not recognised at the time they present with their urinary symptoms. And what kind of bowel problems are we talking about? Well, any, but most particularly constipation, and in many cases constipation leads to overflow and fecal incontinence, called retentive fecal incontinence. But there are a group of children that have no constipation but do have fecal incontinence, called non-retentive fecal incontinence, much less common, but certainly very important as it does associate with certain bladder symptoms. So in children presenting, for instance, to me or someone else with bowel symptoms, around 30% will have urinary symptoms as well. Often they won't declare them. I have to ask. I say, are there any wet pants? Is there any enuresis? And certainly in children with this more rare condition, the non-retentive fecal incontinence, many of those will have daytime or nighttime urinary incontinence or both. And as Wendy touched on, treating those bowel problems, identifying and treating those bowel problems can resolve or improve urinary symptoms. And Wendy said improve, and I'm sure kids that get to tertiary level urinary treatment, very few would resolve with treating their bowel problem, but certainly in primary and secondary care it's not uncommon for a child with constipation to present with a whole lot of urinary tract infections or daytime urinary incontinence when they're constipated, and treating just the constipation resolves all the urinary issues. So it's fundamental that you know that constipation and bowel issues really need early attention, because it might save an awful lot of trouble in terms of investigations and treatment for urinary symptoms that could be addressed very simply. And in terms of how these numbers are derived, how do we know how many children with urinary symptoms have bowel symptoms? A recent study, and there are many, as Wendy mentioned, but having just been talking to the Amsterdam people, I'm quoting their work at the moment. Rosa Burgers did her PhD on this combination of symptoms, and she looked at the children coming to their urology clinic in Amsterdam, and the children were looked at for bowel symptoms using a questionnaire, an examination and an ultrasound of their rectum via their abdomen. And she excluded any child who was known to have a bowel problem, so she didn't keep children in her study if they were already on laxatives or already had a spinal problem. She just looked at the children presenting solely for treatment of their urinary symptoms. And the kinds of children, the diagnosis in the urinary sense, 41% had an initial diagnosis of dysfunctional voiding and 34% had urge incontinence or overactive bladder. But of these children, more than half had some sort of bowel problem that hadn't been recognised prior to her checking it with her questionnaire and so forth. Most of them had functional constipation, and a smaller group, but not insignificant, 10% had functional non-retentive fecal incontinence. And both the dysfunctional voiders and the urge incontinence patients had more constipation than anything else, but the big thing to note is that the children with urge incontinence were the ones that, if anyone was going to get non-retentive fecal incontinence where they were defecating without, having fecal incontinence without constipation, it was going to be the urge incontinence group. And she wondered whether this was because they weren't able to recognise the call to stool or the urge to void, or whether there was a problem with holding on once they had that urge in time to get to the toilet, or whether there were obviously much more subtle central or peripheral sensory or motor dysfunctions in those children. So non-retentive fecal incontinence wasn't very common in the children who strained to void, but it certainly was quite common in those children with urge incontinence. And she also did a study, these children that have, you've just seen a whole lot of urodynamic pictures, and she did a study to see, well, what happens with a full rectum on the urodynamic testing? Because clearly, if that influences the testing, it's very important to standardise that before you start doing these tests and trying to make diagnoses based on the findings. And so these are studies you can really only do in Holland. I don't know how they get permission, but they did a rectal balloon in children who had come for urodynamics. And they found in 70% of children inflating a rectal balloon to stimulate a presence of emotion in the rectum caused some sort of change to the bladder, either its capacity, its sensation, or its overactive contractions. And in half, when the balloon went down, the bladder went back to the baseline, but in about half, the bladder continued to show different function after that balloon was deflated, suggesting that something had changed with the nerve or muscle control of the bladder to do with that recent distension of the rectum. So it's not as simple as just a big stool or a big balloon in the rectum is squashing the bladder and reducing its capacity. It's nowhere near as simple as we thought. She found the changes were quite unpredictable. You could have an increase or a decrease in your bladder capacity, or it might not even change. You might have increase or decrease in your overactivity, and you might have an increase in sensation, or it might not be affected. So, as you would expect, if you had a big balloon in your rectum squashing your bladder, you might have an early desire to void at a lower bladder filling volume, but half of them didn't. So she grouped them into patterns, and around a quarter, when the balloon went up, there was an inhibitory response on the bladder. So the bladder capacity actually increased, and the bladder contractions decreased, and the filling perception decreased, exactly the opposite to what you might think. Nearly half had the stimulatory pattern which is probably what I would have expected, where the bladder capacity was reduced, the filling perception was increased, and they had more uninhibited contractions. And in about a third, there was no perceptible change. So reasons why that might be the case: obviously, if you've got a distended bladder rectum squashing your bladder, you might compress its volume, you might obstruct its outlet. There are, of course, similar nerve and muscle pathways modulating the function of both these organs, as well as just being physically close together. You could have inappropriate pelvic floor muscle contraction, or sometimes you might have some rare disorder that affects both systems, like you might have, there's a thing called hollow visceral myopathy, where you have baggy, weak internal organs. So your bladder's baggy and big and weak, maybe 5 litres in a teenager type of size of baggy and weak, and your bowel can be baggy and weak. So that muscle disorder can affect both organs, and maybe there are more subtle muscle or nerve disorders that also affect both organs that we're yet to establish. And certainly in very common scenarios when the child's got a behavioural reason for dysfunction of both organs, they won't go to the toilet if they're hanging on.
What that's called?
Hollow visceral myopathy. So the viscera, like the gallbladder, the gut, the stomach, the bladder, are all enormous and baggy. So how would you recognise these sorts of problems? Because that's critical if you're seeing these children. In my case, fecal incontinence is usually reported because they're coming to me for it, but if you're seeing a child with major urinary problems, they may have slight staining with faeces in their undies that they haven't even thought to mention, and that is really important. So always ask. Many parents are quite unaware their child is constipated, and that's a common theme through all the children's constipation literature, that many parents just do not have any idea that this is what's happening. But you can detect it with simple questions and a basic physical examination. If you're not a doctor, you're not expected to do a full physical examination, but even just feeling their tummy to see if you can feel what feels like a pregnancy arising from the pelvis, as in a big fecal mass, that's quite a useful skill to have. And if you are a physio or someone that has an ultrasound device, that is really helpful because you can quickly scan the rectum and see through the tummy how big it is and whether it's packed with poo. And there are very simple standardised criteria used across the world that you can tick off and see if your child has these problems. The criteria that, the most current criteria that we use in gastroenterology is the Rome criteria, and they've had various iterations, and we're up to Rome 3 now. Every few years, experts go to Rome and by consensus determine criteria. They're very like the headache criteria for migraine. If you've got a condition like functional constipation or irritable bowel or colic in babies or migraine, where there's no blood test and there's no x-ray and there's no objective test to diagnose it, you need really clear symptom-based criteria to make that diagnosis in the same way across the world. So just like the headache criteria for what is a migraine, what is a stress headache, we've got criteria for what is functional constipation, what is irritable bowel, what is non-retentive fecal incontinence, and those criteria are simple and you can use them very easily in clinical practice. And their website is easily available as a book if you're really interested. So their criteria for functional constipation, and this is in children of the age group we're talking about, so children over the age of 4, you need at least 2 of these criteria. So they might be having infrequent bowel motions in the toilet, less than 2 per week. They might have fecal incontinence more than once a week. There might be a history of hanging on positions, and I'll get onto that later. You might have heard something about that already, but I'll get onto that as well. Or putting off defecation. There could be a history of painful or hard bowel motions, or a large fecal mass that you can feel in their tummy, or you can see their tummies distended, or you look with your ultrasound, or large diameter stools that obstruct the toilet. Now in Australia our plumbing is fantastic and it's very rare for kids to obstruct the toilet, but in other countries like Europe and Greece and even the USA, the pipes are small and it's really common for kids to come and say, my poo's blocked the toilet. Just in case you need to know, what you do is you get a coat hanger and you unwind the wire and you jig around with the loop of the coat hanger in the toilet until you get the motion to go, flush it away, throw away the coat hanger, just in case you need to know. So, and in these criteria, you need to fulfil your criteria for at least 2 months before you can get this diagnosis. And you don't want to have irritable bowel. There's a big overlap, to be honest, between constipation type irritable bowel and functional constipation. And the thing that determines irritable bowel is if you have tummy discomfort removed by defecation, which of course some constipated kids do, but also changed with either, also the tummy discomfort is associated with a change in emotions, either a change in how often they're happening or a change in their consistency from normal to loose or normal to hard. So that's more points in an irritable bowel direction, but don't get hung up on that because essentially constipation type irritable bowel gets treated just like constipation anyway. And you have to, of course, know that the child doesn't have cancer or a spinal lesion or some other major reason why they have these symptoms. And again, 2 months of symptoms before you're allowed to make these diagnoses based on those criteria. The non-retentive fecal incontinence kids, developmental age over 4, so they should know better than doing a motion in the garden or a motion on the floor. They must include all of these criteria, so they're defecating in inappropriate places at least once a month. They're not constipated by any measure, so they don't answer positively to any of those constipation questions we had just before, and they don't have evidence if you feel their tummy or check them with an ultrasound, and again, no organic cause, and again for 2 months at least. And this is just about the ultrasound, because I know a lot of people do have ultrasounds in their practice, and that can be quite handy. It is very rare for me to do a rectal examination, and I am the poo fairy. But the surgeons call me the poo fairy, sadly. But I get the really bad constipation children, and it is very rare for me to do a rectal examination on an awake child, because there are huge issues towards consent and abuse, and there is a very reasonable test that can obviate the need for that invasive procedure on a child. So I don't routinely do rectal examinations unless they're a perfectly happy spinal child who has no sensation, or they're very used to people around their bottom area. It's very rare for me to go and do a rectal examination. In the old days it used to be said that if you're looking at children with constipation, if you don't put your finger in it, you're going to put your foot in it, and that's just not the case. So I don't advocate rectal examination. I advocate feeling their abdomen and doing an ultrasound if you're not sure. So you ultrasound 2 centimetres above the symphysis pubis, 10 degrees down from the transverse plane. You need a bit of wee in the bladder to see. Normal children have a diameter usually around 1.7, 1.8 centimetres. So if it's over 3, strongly correlates with constipation. So over 3 centimetres from the external wall on one side to the external wall on the other side suggests constipation. That's been validated again by the Amsterdam people in terms of comparison with actual digital rectal examination, and it's a perfectly reasonable alternative. So when we get these children, we take a thorough clinical history, and it depends on your scenario whether that's going to be what you can do, but there are great resources, as I said, both the Impact CD and our Royal Children's CD will have a nice structured history-taking tools for you to use if you want to do that, or send them back to their doctor if you would feel more comfortable if you're not a non-medical person. So we want to know, did they have a normal bowel habit at any stage and then have some precipitating event after which they started holding on to stool? That's a very common pattern. We do a thorough examination. We check they're growing properly because some medical conditions do lead to stunting or even weight loss. And we ask about red flag symptoms. And we ask if they've already known to have constipation, whether they've been stuck on treatment for a long time. That also indicates a need for further paediatric review in case there's some other reason that they're stuck on medication, like they've got cow's milk allergy or spinal problem or something. The red flags that really indicate the need for medical review of this child, and if you're in GP land already, then paediatric review of this child would be perianal disease, so sores or splits around the back passage, blood in the stools, extra-intestinal symptoms of Crohn's or colitis, and that reflects these diseases create inflammation throughout the body, not just in the bowel, so they can often get persistent mouth ulcers, sore joints, red eyes for no reason, poor weight gain or weight loss, or unexplained recurrent fevers, and those are all big warning signs that this child needs medical evaluation. Same if they have symptoms that suggest Hirschsprung's disease, which is HD just there. So if their first newborn poo, that little black tarry poo that they do, should happen in the first 24 hours in nearly everyone, or in the first 48 hours in most normal children. Beyond that, the rate of, if a child passes meconium after 48 hours, the rate of Hirschsprung's goes up exponentially, but there are still normal children who pass their first motion after 48 hours, so it doesn't guarantee they've got Hirschsprung's if they had delayed meconium, but it's a major alarm bell that needs to be further investigated. Also, Hirschsprung's is a disease where the nerves to open the bottom to let the poo out never form, so the back passage is tight. So the poos, if they come out, are often thin like noodles or strips or toothpaste, or lolly bananas rather than iridescent little Mars bar size or bigger. So if they're passing very thin stools, wonder about Hirschsprung's. The other typical thing that mimics Hirschsprung's is food allergy, because cow's milk and other food allergies, we're recognising more and more, can cause anal sphincter spasm, preventing it from relaxing. Exactly like a Hirschsprung's, they can produce these thin little poos. Not all allergy children or Hirschsprung's children do thin little poos. They can get to the stage where everything's so stretched they are able to produce enormous poos. But if they're passing thin strip-like poos, that needs to be investigated because it could mean one of these medical diagnoses. Also, if they're vomiting and they've got, especially if they've got regular vomiting with something green or yellow, like suggesting bile, needs investigation straight away. There might be some sort of obstruction, surgical obstruction, or more rarely a thing called pseudo-obstruction where, like the hollow visceral myopathy, where the muscles are just so weak that it looks like there's something blocking the bowel, but it's just that the whole thing isn't working and the muscles are just getting more and more baggy and stretched. In my business, if I meet a constipated child with urinary symptoms and I treat the constipation and the urinary symptoms aren't getting better, then I want an MRI of that child. And you're not going to MRI every child that you see with urinary symptoms, but that combination, if it's a persistent thing and isn't responding to simple standard treatments for the urinary or the constipation symptoms, in my view, it's very well worth getting an MRI. And specialists can refer for bulk billed MRIs. It's a lot different if you come in the community because it's quite expensive. So paediatricians and subspecialists will refer children for MRIs if there's a troublesome combination of urine and stool problems that aren't responding to simple first-line treatment. Because sometimes there is no sign on the outside of the child. There is no birthmark, no lump, no tuft of hair, no nothing. But inside, the spinal cord can be tethered to the bottom of the bony spinal canal, such that as the child grows in height, the spinal cord's getting stretched and stretched and stretched, and instead of being able to freely rise up the spinal canal with growth as it does, babies, their spinal cord reaches nearly the bottom. In adults, the spinal cord stops around L3-4, so it needs to be able to move, and if it's stuck down at the bottom as the child grows in length, then the spinal cord can be stretched like a bowstring, and that can cause a progressive loss of continence and lower limb function if it's left unaddressed. Similarly, there's a little cyst called a syrinx, which often happens in the thoracic spine. It's an expansion of the central canal and it can squash the continence nerves, and you can't see any sign externally. Often their legs examined normally. So children with persistent bowel and bladder problems, I always do an MRI, and I've found several with that sort of problem. The yield depends on where you are in the system. I get the really hard ones that have had a lot of prior treatment. If you're seeing kids first off the bat as a GP or a therapist, you're very unlikely to come across a child. But if you see a child with lower limb neurology that's abnormal, they're dragging one foot, they stumble a lot, they're wearing their shoes strangely, then highlight that with their doctor, because it's so important to get onto these spinal things before they cause permanent loss of continence or leg function. The commonest cause of constipation, of course, is a little kid who has one hard, scary poo, and then they get a sore bottom, maybe some blood, and then they're scared to do the next poo, so they hang on when they feel the urge, and the next poo is even harder and more scary, and it goes round in a circle such that eventually they're starting to produce poos like mandarins or grapefruits. And those poos get so scary that the child, it can really disrupt the whole family dynamic. Everyone's terrified of poo. And the typical story is they were fine when they were born, they pooed normally for a while, and then something happened to trigger this, such as a new baby came, or the child was sick and dehydrated on one day, or they travelled in a car on a long trip and didn't get to go to do a poo that day. Something really simple usually, and something often forgotten, and then they're withholding and they're doing big poos, and often there's little fecal incontinence when they're trying to do a poo. And so their rectum has gone from normal, and rectum's empty normally and doesn't carry poo all day. We get the delivery of motion a couple of times a day or once a day. We feel it, we do it. We don't carry poo in our rectum. These children carry poo all the time in their rectum, and some can leak out very readily because the rectum is stretched, it's numb, it's weak. Their accidents are not their fault. Often parents feel that the children are doing it deliberately. That is usually very rarely the case. And the parents see that the child's trying really hard because they're red in the face and they smell like a poo's coming, and they're straining to do this poo, and hardly any comes out. But you really need to ask, well, what are they doing when they need to do a poo? What position are they in when they need to do a poo? Because if they're in any of these positions, they are trying really hard to stop that poo come out. So if they're standing very tall like a soldier, or they've got their legs crossed, or they're bracing against the furniture, or they're in all fours, or they're sitting on the floor with their legs drawn up, then they are trying very hard not to let that poo come out. And they often are quite fearful.